Okay, so sorry for the little delay. We have some connection issues, but I think we're okay now. I'm going to introduce our next speaker. She is Shannon Brownlee, MSc. She is Senior Vice President of the Lung Institute. She is Senior Vice President of the Lung Institute, President Dr. Vicky Zenit, and co-founder of the Right Care Alliance. Before joining the Lung Institute, Brownlee served as an acting director of the Health Policy Program at the New America Foundation. As a senior fellow at New America, she published the groundbreaking book, Overtreated: Why Too Much Medicine is Making Us Sicker and Poorer, which was named the best economics book of 2007 by the New York Times. She was a senior writer at US News and World Report and Discover magazine. She is the author of several peer-reviewed articles in medical journals, including a 2017 four-part series on overuse and underuse in The Lancet. Brownlee is currently a lecturer in the Department of Policy and Management at George Washington University School of Public Health and a member of the board of the Robert Graham Center of the American Academy of Family Practice. She holds a Master of Science from the University of California, Santa Cruz. Shannon will present their conference entitled Medication Overload: Why Overprescribing is a Patient Safety Issue. We invite you to actively participate during her presentation. If you have any questions, please ask them in the chat on the left. We will be responding to as many as we can during the allotted time. The rest of the questions will be answered and published in our Q&A section within Patient Safety Day on our webpage, isoponline.org. Without further preamble, please give a warm welcome to Shannon.
Thank you very much, Melissa. I appreciate the very nice welcome, and I'm so honored to be on this, to be speaking at the ISOP. As you can see from my bio, I have a special interest in the problem of overtreatment or low-value care, delivering services to patients that are not effective or are something that they do not want or are inappropriate for them. And so I'm going to talk to you today about something called medication overload, and you may know it by a different name, which is polypharmacy. I want to make a distinction between polypharmacy and medication overload. So polypharmacy is often defined as 5 or more drugs. A patient is taking 5 or more medications. Those are often prescription medications, but they can also be over-the-counter medications. And we make a distinction between medication overload and polypharmacy because it's possible to be taking 5 drugs that are all indicated and all actually beneficial. So that polypharmacy in this case is not actually harmful. But in many cases, taking more drugs does pose risk of harm to patients. And we believe that it's important to recognize polypharmacy as a risk factor, just as having high cholesterol does not necessarily mean that you have heart disease. Having 5 or more drugs, taking 5 or more drugs does not necessarily mean that you are suffering harm. But medication overload is when harm is starting to occur, either because the patient is taking a drug that they should never have taken and yet they are suffering the side effects, or they are taking a drug that is indicated but not beneficial for them, and they are suffering the side effects, or the drug is no longer necessary. For example, a patient who is in hospice on statins. Statins are no longer necessary. And then there are unnecessary over-the-counter drugs and supplements. So we're very interested in the fact that the WHO, the World Health Organization, has now declared polypharmacy a major and growing public health issue that occurs in all healthcare settings worldwide. We've done most of our work focused on the US, where polypharmacy is a significant problem, but it is very clearly a problem in developed and in fact in low and middle income countries around the world. So what are some of the harms of medication overload? Multiple studies have shown that the risk of, I'm being told that I can make this full screen. I'm going to try to do that. Here we go. Slideshow, sorry.
Dear Shannon, you can put at the bottom of your presentation, share
Yes.
it to see the whole slide. Go to the right, left, to the bottom, and you'll
Yes.
see like show as a presentation.
I'm trying to get it to show as a presentation. For some reason, come on, you can do this. Okay, slideshow, start
From current
slideshow.
slide, from current, the second choice, from current slide.
Yes, here we go. Great, thank you. It wasn't working before and now it is, so I'm very glad. So, so multiple studies have shown that the risk of serious adverse drug events goes up with the number of medications. So every additional drug increases the risk of a serious adverse event by about 7 to 10%. Now, the reality is that if a patient is on one inappropriate drug, they can certainly suffer the risk of adverse events. But the more drugs the patient takes, obviously, many of you know this implicitly, the more drugs a patient takes, the greater the risk of serious adverse drug events. So what are some of the harms? We know that the consequences can range from dehydration to dizziness, drowsiness, fainting, nausea, delirium, dementia, falls, serious bleeds, organ failure, and death. And we're particularly concerned about these risks when patients are older than the age of 65. So for older adults, taking 6 to 9 medications is associated with a 59% greater chance of death in older Americans. Older patients who are taking 6 or more drugs in the hospital are twice as likely to experience delirium, particularly in the ICU. And taking 10 or more drugs is associated with a 50% greater risk of falls for older adults, and we know that falls can often result in death. So medication overload around the world is a significant problem. In Canada, 66% of adults age 65 are taking 5 or more medications. These are old data. This is from 2012. In Scotland, and I know you'll be hearing or have already heard from Alpana Mayer, 1/5 of all adults in the Tayside region of Scotland were on 5 or more medications over the previous 3 months. In Ireland, 60% of adults are given 5 or more medications over a year, 42% in Germany, Italy, 11% of adults age 65 or older are taking 10 or more medications. So we know that this is a widespread problem. In the United States, it is also a widespread and serious problem. And it has widespread consequences, both for harm to patients and for the costs of all those medications. So we know that 5 million older adults in the US sought medical attention for a serious adverse events in 2018. And there has been a 200% increase in polypharmacy in the United States over the last 20 years. That has led to 750 hospitalizations every day due to ADEs in older adults. And we project that over the next 10 years, the US will spend $62 billion in unnecessary hospitalizations, and there will be 150,000 premature deaths from polypharmacy. So this is a serious problem in the United States, as it is in other countries. So I want to show you a little video right now, and I need Melissa's expert help in this, but this is a video that was shared with us by Dr. Tom Perry from the University of British Columbia in Canada. And this is a patient of his who came into a clinic at the hospital with various complaints, and he began questioning her about the various drugs that she was on. And I'm going to show you this little video, and then later I'll show you the after she was deprescribed. She had many of the drugs deprescribed. So Melissa, if you could play the video, thanks.
Yes, Shannon, give me just 1 second. And
Okay.
I will share it.
And do you want me to stop the screen share?
Yes, please.
Okay.
But if you want, you can also share the video on your computer. You just have to go outside PowerPoint and just put it as a normal video.
I can share the video.
Yes.
Unfortunately, I don't think I have the video.
Okay. Don't worry.
We sent it directly to you.
Here there is. So just I'm going to share my screen.
Great.
Can you see my screen now?
Yes.
Perfect.
Here we go.
I feel out of it.
Can you explain what the sensation is?
Well, I feel a little bit dizzy and dazed, a little bit, still a little of nausea here, and just terribly weak. I feel like just collapsing on the floor. I feel so weak, I have to do this.
I understand that. And then maybe you could explain to me what these are for, if you know.
Well, I know because I can read on them.
Mm-hmm.
It says oval brown pill. That's probably it for moods. Mirtazapine.
Do you have any opinion on what it does?
Well, I think it probably lifts my mood because I'm often naturally sort of depressed and it's I seem to feel peppier. Maybe that's not it, but the next one is PMS Qdenapine, 300 milligrams. I think relax me so that I sleep better because I've had
She has insomnia.
Do you know anything more about that drug, quetiapine?
no,
No. Do you have schizophrenia?
I didn't think so. Maybe I do.
Would it surprise you if I told you that drug is officially approved in Canada for psychosis and schizophrenia?
My goodness. Then these I definitely need. It's Zopiclone.
Okay.
The next one, take 2 tablets in the morning and 1 in the evening. It's Lyrica. He told me those pills were for pain.
Where was the pain that they were supposed to treat? What part of your body?
Stop and think. Oh, I have various aches and pains.
Do you periodically sort of stop to ask yourself, I wonder which one of these I really like and which one I don't like? Or not?
About drugs?
Yeah.
No, I think if I had to choose, it would be my sleeping pills, because I have such trouble with insomnia.
Am I the first person to ask you this much detail about your pills?
Thank you, Melissa.
Okay. I'm going to give you back the control of the presentation. You can
All
share.
right, and I will share my screen
Yes,
when you're
ma'am.
done.
Yes, ma'am.
Okay.
You can share your screen now.
Okay. So you should see my slides now.
Yes, ma'am.
Great. And I should be able to get to the next slide. It doesn't seem to want to do that. There we go. So we at the Lown Institute, and I didn't tell you what the Lown Institute is where I work. We are a nonprofit, an NGO, a think tank. We look at healthcare issues exclusively, and we're based in the US in Boston, Massachusetts. And we spent 2 years looking at the problem of medication overload and issued 2 reports, one of which looked at the prevalence of the problem and examined some of the reasons that this is such a big problem in the United States and in other countries. And the second part of the project was developing a national action plan. We relied on a large working group of experts, pharmacists, physicians, nurses, patients, and together we developed an action plan to think about how to address this very widespread and prevalent problem. So the action plan really, did I skip a slide? Yes, I did. So it's important to understand what drives medication overload and polypharmacy. And we realized that it really breaks down into 3 main areas. The first is the culture of prescribing. It's as if we have an idea in this country and probably in other countries as well that that there is a pill for every ill, that no matter what is going wrong with you, the first way to treat it is to take a pill. And we've been primed to believe that in part because of pharmaceutical company marketing to both clinicians, doctors, pharmacists, nurses, and to patients. And one of the effects of this marketing has been that the downside of drugs, the side effects of drugs are often downplayed, and the potential benefits are enhanced or are emphasized. And so patients often don't think about the potential downsides of taking another drug. Another aspect that emerges is the fragmentation of care, which is the third on this list. And in the United States, this is a particularly bad problem. It may be better in other countries where you have more an actual system of healthcare, but in the United States, we have a market of healthcare. And so one of our biggest problems is that what the specialist does in terms of prescribing stays opaque to the primary care physician. So the primary care physician sends the patient to the cardiologist, for example, and the cardiologist does a series of tests and then gives the patient 3 prescriptions for a statin, for a blood thinner, and for a high blood pressure medication. And when the patient then goes back to the primary care physician, that primary care physician has no idea that the patient is now on these 3 different drugs. And so if the patient has side effects from any of those drugs, the primary care physician may then prescribe another drug to treat the side effect, not knowing that the side effect is not a manifestation of a new disease, it's the side effect of a drug. So this is an enormous problem in this country, and patients often will go from the cardiologist to the rheumatologist to the nephrologist and then back to the primary care physician. And the only person who knows what drugs they are taking is the patient, and the patient often doesn't really know what those drugs are for, what the indication is. So the third large category of problems that drive polypharmacy and medication overload in the United States are information and knowledge gaps. So in this country, clinicians are not actually trained to recognize when a patient needs to have drugs de-prescribed. Pharmacists are better trained often than physicians or nurses are, but even they are often following clinical guidelines, and that knowledge gap affects those clinical guidelines. So that many clinical guidelines, very few clinical guidelines say you should consider stopping a drug at X point. They often will say, if the patient doesn't respond, up the dose, or if the patient doesn't respond, add another drug, but they will not say when to withdraw drugs or when to step dosages down. So when physicians and pharmacists follow clinical guidelines, they may be inadvertently giving patients more drugs or higher doses of drugs that are necessary. And we know, especially for older patients, that doses of drugs that work for a 25-year-old are really not appropriate for a 75 or an 85-year-old. So we have a culture of prescribing that drives it. We have information and knowledge gaps, and we have fragmentation of care. And one last thing on the culture of prescribing. One of the things that it does is it interferes with the ability of the patient and the physician, or the patient and the nurse, or the patient and the pharmacist to actually communicate about the problem of polypharmacy. Physicians are often afraid to say to the patient, you know, you're on an awful lot of drugs. Maybe we should think about getting you off some, or at least lowering the doses. And physicians are afraid to say this because they worry that the patient will feel as if the physician is abandoning them. We did a series of focus groups, and we found that physicians worried a lot about talking about deprescribing drugs because of this fear that the patient would feel abandoned. And patients, for their part, assume the physician would never prescribe a drug if it wasn't good for the patient. They don't think about risk and benefit, or a risk of harm and risk of benefit. They say the doctor prescribed this because it's good for me. And they also feel that if they say anything about all the drugs that they're on, it is an implicit criticism of the physician who may have prescribed the drugs in the first place. So I'm gonna, oops, I think we are skipping. I am not going backwards. Why is this? Here. There we go. So we focused our action plan on four main areas, on people, the people who could take action to do something about it. And I'm going to talk mostly about the last one, which is what health systems and clinicians and patients can do. But I'll talk briefly now about the first three. So national policymakers, or local policymakers in the US, that would be at the state level and at the federal level. One of the things that they need to do is acknowledge the need to see polypharmacy and medication overload as a patient safety problem, and to start listing polypharmacy as a patient safety indicator and track the data. This is a very important role that policymakers can have. Public health organizations need to help raise awareness about medication overload, and that's not just awareness among patients. We were really quite surprised in doing a series of focus groups to find that clinicians, physicians, may not be aware of how widespread the harm is of patients who are on 5, 6, 7, up to 20 drugs, and that they are at much greater risk of harm with each additional drug. The physicians really were not as aware of this as we thought they might be or should be. I think pharmacists are a little bit more aware because they get more training. And that leads to the next issue, which is health professional schools. Training for clinicians, for nurses, for doctors, for pharmacists needs to incorporate deprescribing into their education so that they really understand how to spot when a patient needs to have an assessment of the drugs that they're on. They know how to do that assessment, and they know how to deprescribe, how to take the patient off of drugs or to de-escalate the dose. So the final area is for health systems and clinicians to focus on, and this is implementing something that we call prescription checkups. Now, you may think of prescription checkups in a different way. You may have heard there are many terms for something related. Medication therapy management is sometimes a term that's used in the United States, medication reconciliation. And there are some really significant differences between these ways of looking at the drugs that a patient is on and a prescription checkup. You can think of them as deprescribing visits to a certain extent. And there are international efforts underway now to actually do some of this. There is the deprescribing network in US. We have a new deprescribing network in the US. There's already one in Canada, Australia, England, Northern Europe. The Sympathy Project, which is an EU-funded project, is a very important initiative, and we look forward to seeing the results of that. There's the International Group for Reducing Inappropriate Medication Use, the Briere Describing Team at McMaster University, which is in Canada. And then there are deprescribing initiatives that are being led by the US Veterans Program, U.S. Department of Veterans Affairs. So a prescription checkup is a medication review that makes relieving medication overload the primary focus, and it uses a shared decision-making process to be able to get patients on lower doses of drugs or to take them off unnecessary or harmful medications. And this picture, I think, really is worth 1,000 words. This is a picture on, I believe it's on your left, of a week of medications before and then a week of medications after for a single patient. So all those pills on the left were what one patient was taking over the course of a week. And after deprescribing, after doing a prescription checkup with that patient, those are the drugs, the number of drugs the patient was taking was significantly reduced. So prescription checkups involve 4 very discrete steps. The first step is when the patient comes in. This probably should be performed in a primary care office setting. It can be performed by a pharmacist. But the first step is to do an inventory of all of the drugs that the patient is on. And in other countries, this is often a little bit easier to do. In the United States, it's incredibly hard to do because despite the fact that we have electronic medical record systems, they actually do not share information. And so often clinicians in the United States who want to do a prescription checkup need to ask the patient, him or herself, to bring in all of their medications in the bottles. And unfortunately, those prescription bottles don't always say what the indication was. They don't always say what the, whether the high blood pressure medication was prescribed for. So this is a problem. The inventory is actually a very difficult part of the process. The second part is inquiry, where the patient is encouraged to discuss what they understand about each drug and what their goals are for taking the drug. And they need to understand what the potential benefits are of the drug and what the potential harms are. They need to understand this so that they can really start to think about whether or not they want to stay on one drug or another. The third part is intervention. The patient and the clinician create a plan. And the plan is actually really important for many drugs. As all of you know, certain drugs really can't just be simply stopped. They have to be slowly tapered. So, the drugs are effectively deprescribed by stepping down doses, or some drugs can actually just simply be stopped. And sometimes the patient will say, well, I really want to stay on that particular drug, and the clinician will agree. And the final step is follow-up. It's important that the clinician check in with the patient a month, 2 months, maybe days down the road to see how they're doing, to make sure that discontinuing a drug has not led to a resurgence of symptoms or some other downside for having stopped a drug or brought the dosage down. So let's look what a successful prescription checkup, what the effects of a successful prescription checkup are like. And again, Melissa, if you could, I'm going to stop sharing, and if you could share the second video.
Sure, I have it open. Hold on. Can you see the video now?
Not quite yet. It's still showing your.
Okay. So
yeah.
I choose the wrong screen. There it is.
There we go. Perfect. 10 days later.
As I understand it, you stopped taking the Seroquel or quetiapine?
Yes.
And you also stopped taking the Lyrica,
Yes.
which is also called pregabalin.
And you had put on it was useless. Probably useless.
Have you noticed any difference since you stopped those?
I feel very much better.
Can you describe what the difference is?
Well, for one thing, I feel more cheerful. Not just physical things, but I feel more cheerful, and that's one of the things that's made me realize that something's different. Because I used to be rather serious and sober all the time, and now I feel happy and good.
Do you think there's any difference in the clarity of your thinking?
Maybe there is, you know, I don't think about what I think.
The last 10 days you haven't been using any alcohol, right?
No.
And is there any difference to your dizziness
Yeah,
or?
it is better.
One of the big issues was you said you weren't sleeping well.
That's definitely better. It has definitely been better.
Even though you stopped taking some drugs?
Yeah, even though I stopped taking some things.
Well, I think you look different in a positive way.
That's good.
You're a very beautiful woman.
Thank you.
You're welcome.
You can share your screen.
All right, are we ready for me to share?
Yes, ma'am.
So that's quite a difference, isn't it, in the before and after? And we received a number of slides from Dr. Perry showing very similar kinds of results before the patient, when the patient was taking a number of drugs, and after when the drugs had been deprescribed. Some of the drugs had been deprescribed. So this is a pretty dramatic example of what of the effect of deprescribing can have on a patient's outlook, on their mood, on how they feel, and I believe on their health as well. So let's see if my little slide will go forward, please. Here. There we go. So patients and families can have a role in this. This is not all on the clinician. So if there are any patient representatives in the audience, which I hope there are, I hope you will think about how your organization can disseminate this information about the important role that families and patients can play. Communication is everything, and patients have to ask questions. And there are just some very, very simple questions that they can ask. If a family member is on a lot of medications and your family feels that there's a problem, you can ask on behalf of the patient. Patients can also ask on behalf of themselves, do I really need to take all of these drugs? What is each drug for? It's important that patients understand that. What are the side effects of each drug? And can I stop taking one or more of them? This is not a bad question to ask your physician. This is a very reasonable question to ask a physician. So patients can have a real role. And so if you want more information about our work, you're welcome. We would be delighted if people would go and download our report on the problem of medication overload and the action plan. We do not represent any large organization. We're a small think tank, and so we don't actually have a real role to play in implementing a national action plan, but we would be very interested in hearing from organizations like Sympathy and others, and the deprescribing organizations on whether or not they think the action plan has any merit or any use in their countries. And with that, I would be delighted to take any questions you might have, but first I want to say thank you in as many languages as possible for giving me the honor of speaking to this wonderful group. Thank you.
Thank you so much, Shannon, for this great presentation. We have some questions from our attendees.
Right.
Our first question is, what are some of the biggest challenges clinicians face when deprescribing a medication to a patient?
So I think one of the biggest challenges is the communication and the assumption on the part of the clinician that the patient will feel abandoned. This is a real barrier for clinicians. And so they need to learn, we could even come up with a few little scripts, which are little sets of words that clinicians could use to open the conversation with patients about how to deprescribe. The other barrier is they don't actually know how to deprescribe. They are not actually trained how to deprescribe. Pharmacists are better trained in this, and so clinicians may need to get the advice of a pharmacist. That's not always readily available to primary care physicians in the United States. I would hope that pharmacists were more integrated into primary care practices in other countries.
Great, thank you so much. Our next question says, generally, the elderly patients relate their health with the amount of drugs that they take because this is what we have taught them. It has been easy for this group of patients to accept the accompaniment, intervention, and change of these therapies.
Is it easy for patients to accept this?
To accept that.
It's surprising. I think it's not as hard as we might imagine. It may, in fact, not be as much of a barrier as we think. We did focus groups with a lot of patients, and well, not a lot, but a number of patients. And some of the patients were wearing pearls and lived in the penthouse, and some of the patients we talked to were the doormen at the apartment building. So there was a real range in education level, in race, and patients generally understood when they were on too many drugs and they didn't want to be on them. And so I think what patients need to do is to be able to understand that they can ask that question. Is there a way for me to be on fewer drugs? And that they should ask that question. But that's going to take a sort of re-education of both patients and clinicians and greater awareness that this is a problem.
Okay. The next question says, my question, all peoples are the most risky population in COVID-19 pandemic. That lead to increase the number of medication taken by them. Are there any new methods of prescribing practice will done or create to minimize harms of polypharmacy between such populations?
Wow, gosh, this is a very difficult question, and I really don't know the answer to this question because I don't know all of the drugs that COVID patients end up being on. But I would think that it's very important before prescribing, even before prescribing drugs for COVID, that there be a retrospective look at the drugs that the patient is already on to really make sure that there's not going to be drug interactions and to try to find ways to reduce the number of drugs the patient is on.
Right. The next one says, how can we overcome some barriers that clinicians impose once we are talking about deprescribing a patient?
I'm sorry, could you repeat the question?
Sure. How can we overcome some barriers that clinicians impose once we are talking about deprescribing a patient?
So I would love to call on my colleague, Judith Garber, who is on this call, and ask her to respond to this particular question. Judith, if you're there.
Hi, yes, I can't get on video, but I'm unmuted. So this is about the barriers that clinicians face when they're deprescribing a patient, how to overcome these barriers. I think that part of it is information. So clinicians should be empowered by knowing that patients are willing to deprescribe if clinicians suggest it. There was a great study by Emily Reeve that asked a lot of patients who are on multiple medications, would you be willing to deprescribe if your doctor said it was possible? And more than 90% of them said they would be willing to. So I think knowing that could be a way to overcome the barrier. Clinicians may be scared to deprescribe because of what the patient will say, but knowledge is power in this case.
Maybe what the attendee was asking is about the clinician imposing those barriers, like if the health provider or the doctor don't want to deprescribe a patient because maybe he's afraid or is not sure about how the health will improve.
Well, that's interesting. So as in, how can they get the barriers from other clinicians, do you mean?
Yes.
I think that's a really tough because there's a lot of power dynamics there. As in, if you were a clinician, someone else prescribed that medication, it can be a little awkward to say, well, you prescribed this, but I'm going to take it away. So I think there have to be, again, like clear communications between clinicians to say, well, this may not be right for this patient. Let's try taking them off this. Or you could even say, why don't we try lowering the dose a little bit? So you're not necessarily taking them off the medication entirely, but you're cutting the dose in half. That can be a good sort of middle ground.
Great. We have another two, if it's okay for you.
Yes.
Okay, sure. The first one, it says, in the USA, there are regulatory changes in line with cut back the medication overload.
Have there been any changes in the United States? That was the question?
If it's a regulatory, I don't know, a regulatory changes that make the doctor or the health provider to minimize or to de-prescribe some medications, but from a regulated way.
So there has been a regulatory change, a payment change in Medicare, which is our insurance for people over 65. But it unfortunately has not really resulted in a reduction of polypharmacy or medication overload, and it's called medication therapy management. For appropriate patients, a pharmacist is supposed to be able to call the patient, discuss their medications, and withdraw inappropriate medications and make sure they're on the correct doses. But in practice, mostly what medication therapy management has resulted in is getting patients onto generic drugs rather than brand names, and thus reducing the cost. So this regulatory change has not actually had the effect that it might have had and probably should have had. Right now, we don't really have any regulatory changes that are really addressing this problem in a significant way. One that would help would be if pharmacists were able to work more closely with primary care offices. And it doesn't happen very often in the US. Pharmacists are a little more integrated into primary care practices in, say, Canada, but they are not integrated in primary care in the US. And that would help a lot to have a pharmacist available to the patient and the clinician in the primary care.
And our last question, it says, have you had to deal with the scenarios where patients take a high amount of natural products, homeopathic substances, etc., concomitant with their medications? What additional challenges this may arise?
I think this is a very appropriate question. So patients think that natural products means that there's absolutely no possibility of harm, and we know that's not the case. That if it's strong enough to actually have a pharmaceutical effect or pharmacological effect, then it's also strong enough to have a pharmacological side effect. And so patients often don't even tell their physicians that they're on supplements, even though the physician may ask directly. The patient may not think it's important enough to tell the physician what they're on. So this is a real problem, and it's partly probably a patient education effort, and that can be done through the primary care practice to say, you know, supplements are real and they have real effects, and we want to know and we want to help you use them. But if the patient's afraid that the physician is going to say, that's useless, you shouldn't be taking that, that's not a good way to open a dialogue with your patient.
Okay, well, thank you, Shannon and Judith, for your answers. The rest of the questions, due to the schedule, will be addressed at the webpage. And
Great.
you did a very great, a very interesting presentation, so thank you so much.
Thank you so much for having us. Thanks, Judith.
Thank you, Judith.
Thanks.